Okay, it's 12:02, so we'll get started. Very excited for today's for our monthly What's New in Addiction Medicine talk today. My name is Paxton Bach. I'm the program director for the fellowship program, and I'm happy to introduce today Dr. Kevin Nguyen. Kevin's one of our current addiction medicine fellows here at the BCCSU. And prior to this, he completed his family medicine residency with the St. Paul's Hospital program, as well as a pharmacy degree at the University of British Columbia. He's going to be talking to us today about a very topical subject, one that's near and dear to my heart. His talk today is entitled Non-pharmacological Approaches for the Treatment of Stimulant Use Disorder. I will leave it to Kevin to take it away, and we'll be back at the end to facilitate questions. Go ahead, Kevin.
Wonderful. Thanks, Paxton. Hey, everybody. Thanks for coming and spending your lunch hour with me today. So we're going to be talking about the non-pharmacological approaches to stimulant use disorder. One second. Okay. My name is Kevin. Nice to meet everybody. Alrighty. So we'll start off with a land acknowledgement. I respectfully acknowledge that I am a humble guest on the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. No conflicts of interest to declare. Okay, so here's an outline of how today's talk will go. I'll start off with some objectives for today's discussion, move on to some background information, then move on to the meat of the topic today, the non-pharmacological approaches to stimulant use disorder, description of what the actual approach is, as well as the evidence surrounding it. Then I'll move on to application to practice and finish up with some resources for these non-pharmacological approaches in the Lower Mainland particularly. Okay, so some objectives for today's discussion. I will outline the burden of disease for stimulant use disorders. I will then describe the various non-pharmacological approaches to stimulant use disorder and then review the evidence for these non-pharmacological approaches. Okay, so some background information so that we're all on the same page. When we talk about stimulants, we're mainly talking about two main ones. One of them is on your screen right now. It is cocaine. So on the left side, we have something called cocaine hydrochloride, which is the powder form of cocaine. It is also water soluble. Generally, folks who use cocaine hydrochloride would dissolve it in water and inject it, snort it, or insufflate it. Generally not smoked because it has a low boiling point, and if you heated it up, it would just burn away essentially. Conversely, on the right side of your screen, we have this thing called cocaine-free base. This is also known as crack cocaine and generally smoked. It's not water soluble, so generally not injected, although someone could dissolve it in acid and then inject it after. Okay, so in terms of our other main stimulant, we have methamphetamines. We have three types on your screen right now. On the very left side, we have the methamphetamine base, which is injected and also consumed orally. In the middle, we have the methamphetamine crystal, aka crystal meth, which I'm sure a lot of folks have heard of, which can be consumed in a variety of different ways, orally, injected, smoked, or insufflated. And on the very right side, we have methamphetamine powder, which can be insufflated and consumed orally as well. All right, so in terms of the burden of disease, so why am I talking about stimulant use disorders? Because the burden of disease is quite tremendous, actually. So from January to June 2022, according to Health Canada, 47% of apparent opioid toxicity deaths involved a stimulant, and there were 5 hospitalizations per day from stimulant-related poisoning. And as per the Canadian Centre on Substance Use and Addiction, which does a lot of analysis in terms of burden of disease, the total cost associated with cocaine use in 2020 Canadian dollars was 4.16 billion, which represented a 30% increase from 2014. And comparatively, for methamphetamine use and other stimulant use, the total cost associated with that was 3.06 billion Canadian in 2020, which represents a 67% increase from 2014. The Canadian Centre on Substance Use and Addiction defines total costs as those relating to hospitalizations and direct physician care and healthcare costs, but also things like loss of productivity in terms of not being able to work while using substances, and as well as criminal justice costs. Okay, so here I have a graph from the Canadian Centre on Substance Use and Addiction. So this graph depicts some selected healthcare costs in terms of of dollars attributed to cocaine and other stimulants, including methamphetamine from 2007 to 2020. If you look at the blue line, which is cocaine, for healthcare dollars, basically since 2010, it's been going down just a little bit and eventually spiked up to 2018. Overall, not really changing that much since 2010. However, what I really want to draw your attention to is other CNS stimulants, the green line, which is their methamphetamines and amphetamines, which has basically been skyrocketing ever since 2010, and it seems to keep on going up. And in terms of healthcare costs, we're thinking anything related to healthcare, emergency department visits for stimulant-induced psychosis, hospitalizations, and other physician and nursing time and other things related to that. Okay, so to talk a little bit more about the background burden of disease. So this is from the BC Coroner's report, which looks at illicit drug toxicity deaths by drug types relevant to the type of death. Basically, the coroner does an assessment and ascertains which substances were relevant to the drug toxicity. So if you look at the top figure here and you look at starting with cocaine, the number in terms of how relevant or how particular it is to illicit drug toxicity deaths hasn't really increased much, actually has gone down a little bit. But if you really look at the methamphetamines and amphetamines, since the early and mid 2010s has gone up a lot from 20-ish% all the way up to 40% implicated in drug toxicity deaths. Okay, so in terms of the bottom figure, the BC Coroner's Office has been doing this expedited toxicology testing where they can test different substances for a person who has unfortunately overdosed and died very quickly. And they found that stimulants were implicated in 72.6% of illicit drug toxicity death in 2022, and so forth in 2023, 70%. So quite a significant number, as you can imagine. Okay, so to hammer the point home, there was a survey done by the Canadian Centre on Substance Use and Addiction of folks who are accessing harm reduction services, and of these 1,500 some odd people, cocaine and methamphetamines were the most commonly reported substances to be used in the past 3 days. And what's particularly terrifying is that from 2019 to 2022, fentanyl and related analogs were detected in 3.2% of stimulant samples. Obviously very scary in terms of overdose, unintentional overdose, compared to just 2% prior. Okay, so moving on from the burden of disease, in terms of the treatment of stimulant use disorders, pharmacotherapy. So as per the British Columbia Centre on Substance Use Practice Update in 2022 for stimulant use disorders, as well as the major American guideline, the Substance Abuse and Mental Health Services Administration. The evidence for stimulant use disorder in terms of pharmacotherapy is limited and inconclusive, no approved medications. However, the non-pharmacotherapy approaches are currently the standard of care for stimulant use disorder, which is why I'm doing a whole presentation on non-pharmacotherapy approaches. Okay, so in terms of the non-pharmacotherapy approaches I'll be touching on today, here's a list of them. So I'll start off with contingency management, then cognitive behavioral therapy, then the community reinforcement approach, then 12-step programs, then the matrix model, and then bed-based treatment. I will probably spend the most amount of time on contingency management, as it is, spoiler alert, probably the most effective, and a lot of folks are somewhat familiar with that one. I feel a whole presentation could be done on just contingency management, so I only selected a few nuances of contingency management to speak about today that I found particularly interesting and pertinent. Alrighty, so contingency management. So what is contingency management? At its core, contingency management is a type of behavioral therapy where individuals are rewarded or reinforced for a positive or some type of desired behavior. In the context of substance use, the positive reinforcement is generally some type of prize, like a gift card to a specific place, or some type of voucher that can be traded for some type of prize, or a chance to win a prize, like a draw to win a prize, or even just monetary incentives. Generally, most programs for stimulant use disorder, when it comes to contingency management, will involve a urine drug screen if the desired behavior is in fact abstinence from stimulants. Okay, so that we're all on the same page regarding contingency management, given that it's kind of a complicated subject. For example, if someone was doing a contingency management program for stimulant use disorder, let's say our desired behavior is abstinence from stimulants, so we would be able to verify this through urine drug testing. So in our example, or most programs, urine drug testing will be done like twice a week. It would have to be done at least twice a week. to get an accurate, I guess, representation of someone's use, because if it was just once a week or less, someone could conceivably plan their use so that it's out of their system by the time they're tested and then start using it again. In terms of the prize, oftentimes money oftentimes draws into a prize, which I will discuss in a little bit. For example, you could start at $1, and generally for contingency management, the prize will escalate at a predetermined rate according to whatever the program is. For example, it could be $1, and then for every consecutive desired behavior that's shown, it would increase by $1 or something like that. So for example, if you go to 8 consecutive urine drug screens that are appropriately negative, then you could have $8 or 8 draws to a prize or something similar. Okay, so if the desired behavior is not displayed, for example, someone's urine drug screen lights up for cocaine or methamphetamines, they would drop back down to somewhere in the prize ladder. Oftentimes it would be all the way to the beginning of the prize ladder. Other times, depending on the particular program, it can be like halfway or other ways as well. Alrighty, and the program length is not an indefinite program when someone enrolls in one. It will range. Sometimes 8 weeks can go all the way up to 16 weeks, or however long the contingency management staff want to run the program for that particular patient for. Okay, so does contingency management actually work? It is supported by a large body of evidence. There was this large 2018 systematic review and network meta-analysis of 50 RCTs comparing psychosocial interventions for cocaine and amphetamines. I have here an excerpt from that particular paper, which is this forest plot looking at its effectiveness when compared to treatment as usual. In terms of treatment as usual, the paper defined this as any non-specific therapy or any unstructured, non-manualized therapy like case management and other things like that. So if you look at here, I'll review some of what we're looking at since I'll be referring to this a little bit more in the presentation. If you look at the top bullet and confidence interval, the dark blue line is abstinence at 12 weeks, which clearly favors the intervention for this would be contingency management compared to treatment as usual. And then below that, we have this green line, which is abstinence at the end of treatment. So it seems or it appears that contingency management is effective at promoting abstinence at the end of the treatment program, however long it is. However, interestingly, if you look at this middle aqua blue line, that's abstinence as long as follow-up. So the program is done, and then whenever the follow-up is done, it appears that the contingency management or the effects from contingency management wear off and they're not favorable compared to treatment as usual anymore. However, to wrap things up, the bottom two red lines are basically dropout rate or acceptability, and contingency management seems to be more acceptable than treatment as usual.
Did they like describe what their actual, I'm curious what their prize scales?
Yeah, I'll get into that into a bit. Yeah, thanks for coming. We're gonna hold the questions to the end, actually.
Okay.
Yeah. Okay, so some more evidence backing contingency management, more updated evidence. So a review of reviews was done in 2020. Contingency management alone resulted in reduced cocaine use during active treatment and similar effects for methamphetamine use. The key here is that it only seemed to work when they're actually engaged in the program. And then once they stop the program, sometime later, it appears to not be that effective anymore or not have any lingering effects. Okay, so from the same paper that I'm referencing, you can combine contingency management with a lot of different things. The key point here is that even if you combine it with several different things, it still might not have effect in terms of follow-up. If you look at this bottom part, contingency management and cognitive behavioral therapy, effective at 12 weeks, effective at end of treatment, it seems that in follow-up, not so effective anymore. And also people really didn't like, not that acceptable compared to treatment as usual in terms of the bottom 2 points. Same thing with contingency management plus 12-step, very large confidence interval because there wasn't that many studies, but pretty mixed data if you look at that. What's really key here is that if you look at contingency at the very top, if you look at contingency management plus something called community reinforcement approach, which I will discuss in some detail in a little bit, that's basically the only intervention that this paper found to be effective in terms of during the actual treatment at 12 weeks, at the end of the program, and actually in follow-up, still seem to have some effect in terms of someone's abstinence for stimulants and seem to be acceptable as well. Okay, so just to kind of summarize, contingency management plus community reinforcement compared to treatment as usual was more effective than contingency management alone during treatment and at the end of treatment, and still had an effect at the longest follow-up after treatment. And this paper basically concluded that contingency management and community reinforcement approach combined together is the most effective and acceptable intervention for short and long-term treatment of individuals with stimulant use disorder. Okay, so a little more into contingency management. So there are various types of contingency management. Two main ones I'm going to talk about are voucher-based reinforcement therapy and also prize-based, also known as fishbowl. So when contingency management was studied or tried in studies a long time ago, the first way they did it was voucher-based reinforcement therapy. This is when the desired behavior is rewarded with a voucher, which would be exchangeable for goods and services, or monetary incentive each time it's performed. So there wouldn't be a draw into a prize or anything. You would get some type of prize when you displayed the behavior, and generally be escalating in terms of prizes or amount of prize as well. However, a lot of studies particularly found that could be quite costly and cost up to like $1,000 American per patient for the entire duration of the contingency management program. Voucher-based. So some very smart person decided that to try as a cost-saving mechanism, cost-saving way, they came up with this prize-based or fishbowl method, which is basically the desired behavior is rewarded with a chance to win a prize each time it's performed. So they wouldn't automatically get a prize, but they would get a chance to win a prize or draw into a prize pool, and generally less costly than the voucher-based reinforcement therapy. And for both of them, generally the prize would be escalating. So for example, with the prize-based, if someone displayed a appropriately negative urine 4 times in a row, they would get 4 draws into the prize pool. Okay, so a little bit more on prize-based or fishbowl. So they call it fishbowl literally because they would use something that looked like a fishbowl that was clear like that, and they have slips of paper in it, each ascertained or ascribed to some type of prize. So display this appropriate behavior or desired behavior that you get drawn to the prize. In terms of the prize or the contents of the prize pool, there could be a lot of variations in how you could do it, but an example would be, let's say you had 100 slips of paper. Usually half of them would say something like good job and not be an actual monetary prize of some sort, and the other half would be some type of prize. And then usually of those prizes, there'd be one jumbo prize worth around $100, and then a large amount of small prizes, a smaller amount of medium prizes, and a quite small amount of large prizes. But you can really kind of change it up based on how you feel or how you want your contingency management program to run. Alrighty. Okay, so does this prize-based fishbowl method actually work? Well, according to the 2014 meta-analysis on this particular method, yes, it does seem to work. Significantly improved treatment outcomes at the end of treatment. However, it does seem that effect was not significant at follow-up, which is a recurring theme with a lot of our non-pharmacological approaches to stimulant use disorder. Okay, so to bring it back to the voucher-based reinforcement therapy a little bit, that also seems to work, or also has evidence proving its effectiveness according to the 2006 meta-analysis. Significantly improved treatment outcomes such as abstinence versus control, and the meta-analysis authors found that delivering the voucher immediately, so during the same clinic visit, resulted in larger effect sizes versus, for example, delivering the voucher like a day after the clinic visit would result in a smaller effect size. And generally greater monetary value is associated with larger effect sizes, but more on that in a second. Okay, so if you took both of them and you compared them to each other, there was a multi-center study in 2005 comparing specifically voucher-based, prize-based versus control, substance use disorders, cocaine or heroin at treatment centers particularly. And they're actually both found to be similarly effective and both much more effective than control. There was like a lenience or a leaning towards voucher-based being a little bit more effective, but not statistically more effective than prize-based. Other considerations that the authors put forth were that, of course, prize-based generally less costly for whichever program is running it. However, patients may prefer voucher-based because it's more predictable in terms of their winnings, and voucher-based may actually take less time and less work for the clinic staff because the prize is actually known, and going through the draws of the prizes when, for example, someone gets 10 draws can be a bit time-consuming for busy clinics. Okay, so the amount of earnings. So the total dollar amount won by someone throughout the entire program is a significant predictor of abstinence, both urine drug screen, via urine drug screen and self-reported, in follow-up for both methods. There are a lot of studies funded by the National Institute on Drug Abuse in the United States, and they demonstrated that generally if someone wins at least $400 throughout the entire program, that is shown to be quite effective or have a large effect size. And they found that lower incentives or lower total amount of winnings don't consistently work. For example, they cited specifically $100 and less. Anything in between is not well studied or kind of not really well known how much effect there is. Okay, so as with COVID, there is a trend towards virtual health and telehealth. So can we do contingency management via those methods, given how complicated it can be? There have been a few studies that have looked at contingency management delivered via mobile phone technology, particularly found to be effective for smoking and alcohol. So basically, these studies had their participants, they all have to have a device, like a laptop or computer or phone, and generally they have an app they'd have to download, and they'd all be given some type of self-monitoring device that could test their abstinence. For smoking, it would be like a breathalyzer looking at carbon monoxide, and for alcohol, they also do a breathalyzer looking at alcohol levels in the breath. Some studies have used a specific bracelet that patients would put or participants would put on, and it would detect metabolites.
We still see your slides, Kevin.
Like I saw them.
Can you guys see my slides? I wonder if
We can still see your slides.
Okay, cool. Next time.
Kevin, can you hear me?
Okay, give me 1 second. Apologies. Okay, sorry about that. Can you guys see the slides now? Ramin?
Yes, we can still see the slides. Can you hear me?
Yeah, thanks, Paxton. Okay, sorry about that. Back to where we were. Okay, so yeah, it seems that some sites are looking at contingency management for smoking and alcohol found to be effective actually, but the participant would have to be given such a device given by the clinic or whichever study was running it. And they would generally, like, for example, do the breathalyzer for alcohol or for carbon monoxide for smoking, nicotine, and then they usually have to record themselves doing it, and they would send it to the study or the contingency management staff, and then they would verify it and then deliver the prize via the patient's phone or email them the prize. So, and there was one particular study that assessed the smartphone smart card application contingency management for patients with stimulant use disorder on buprenorphine specifically. And this one did actually find higher rates of drug abstinence and clinic attendance. However, this one still required patients to come to the clinic to leave the urine drug screen because they couldn't really find a way around verifying someone's abstinence or verifying someone not using particular stimulants. Okay, so as you can imagine, contingency management for stimulant use disorder is generally difficult to deliver because you generally need some way to verify that someone's not using a stimulant. And right now, I guess the gold standard is the urine drug screen. There is some evidence that attendance-based contingency management has also improved treatment engagement and decreased stimulant use. So in that case, the desired behavior would be attending something like attending a virtual group visit or a virtual one-on-one visit. And for that, they'd get whatever the prize would be or whatever the draw to the prize would be. So that could be a consideration for someone wanting to do contingency management virtually. And one could conceivably have their patients or the participants leave a urine drug screen in a lab if they're particularly assessing stimulant use disorder and contingency management. The only drawback of that would be they would probably get delayed result, as the result would be forwarded to whichever physician probably a day later, leading to delayed delivery of prizes, which, as I already mentioned, could have smaller effect sizes than immediate delivery. Okay, so a lot of contingency management has been done in a study setting. However, something that was really interesting was this real-life application contingency management program in a very large scale. So I encourage you all to read this Veteran Affairs Initiative that was started in 2011. So basically, this was a contingency management program for people belonging to the Veteran Affairs for stimulant use disorders. It was implemented at their VA outpatient substance use treatment clinics. Basically, the participants there, or the patients there, were enrolled in this program. The prizes were usually, depending on the specific clinic, usually vouchers or gift cards to particular VA stores and cafeterias. These programs generally were 12 weeks long, twice weekly urine drug screens, escalating draws to a cap of 8 that they set. Expected earnings based on fancy statistics was $364 per participant, and they did a maximum of 164 draws based on the amount of desired behavior that was shown. Alrighty. Okay, so I've talked a lot about contingency management. I could talk a lot about it more, but we move on to some other non-pharmacological approaches. So cognitive behavioral therapy at its core involves psychotherapy aimed at helping someone identify the thoughts and feelings and actions that occur before and after stimulant use. It helps patients recognize situations in which they use drugs and helps them rely on other coping mechanisms instead. The goal is to uncouple their drug use from certain habits and emotions and feelings and behaviors, and use these learned coping mechanisms and skills instead. Okay, so does cognitive behavioral therapy work for stimulant use disorder? Tough to tell. So far, there's limited available systematic reviews and meta-analysis focusing on just CBT alone for treatment of stimulant use disorder. A Cochrane review in 2018 looked at CBT for stimulant use disorder with amphetamine specifically, including 2 RCTs, which showed mixed outcomes, but they were unable to really determine effectiveness based on poor quality data and studies being small in size. Rolling it back to that 2018 systematic review and network meta-analysis, 7 RCTs compared CBT to treatment as usual. And as you can see here, not exactly found to be more effective based on those 7 RCTs versus treatment as usual, in terms of absence at 12 weeks, with the confidence interval crossing the middle line, as well as absence at end of treatment, as well as treatment as well as absence at longest follow-up, but was found to be more acceptable versus treatment as usual. Okay, so basically some mixed evidence or not a lot of evidence for CBT for stimulant use disorder so far. When you look at contingency management versus CBT, there was a systematic review specifically comparing the 2 of them for cocaine. Contingency management, as you would imagine, seemed to be pretty effective in 5 out of 5 trials, and it was superior to CBT alone, which actually CBT alone did not show a significant reduction in cocaine use. Okay, and in terms of contingency management versus CBT for methamphetamine use disorder, some trials have looked at that as well. Significant benefit for contingency management, as you'll probably guessed. However, CBT not found to be that effective, and they concluded that CM alone was, as well as the combination of the 2, was superior to CBT alone abstinence at the end of treatment. Okay, so moving on from CBT, as you guys will probably remember, if you combine contingency management with something called community reinforcement approach, that was the only combination of things found by that specific study or meta-analysis to have effect in follow-up. So what is community reinforcement approach? The community reinforcement approach operates under this principle or concept that someone's substance use is highly tied to their environment or their external factors, such as their peers or their relationship or their job. For example, if they have like a difficult relationship or difficulty with that, they might use substances to cope with that. Or if a lot of their peers use a lot of substances or stimulants, then that would be an external factor influencing them to use as well. So based on that, the community reinforcement approach is basically a multi-layered level of interventions focusing on a specific person, looking at some of the external factors that are related to substance use, and seeing if those could be optimized in some specific way. For example, if they have difficulty in their relationship and they are using drugs to cope with that, such as stimulants, offering marital therapy, or trying to figure out a way to optimize that relationship in order to improve the quality of their relationship and therefore ameliorate that cause or that trigger for their substance use. Alrighty. Okay, so the CRA never explicitly evaluated in systematic reviews, only included a comparison group mostly, therefore really difficult to assess its effectiveness alone. And research on the CRA has focused mostly on it in combination with contingency management, which I discussed a little bit ago. Okay, but walking it back to that large meta-analysis, they did some assessment on the CRA and found it by itself, based on mostly poor quality studies, but found it by itself not to be more effective than treatment as usual alone at 12 weeks of the therapy or the intervention, and also at follow-up. Sorry, also at the end of treatment, but at follow-up may be some effect. And I guess the idea behind that is by looking at someone's substance use and the external factors and improving those, they will not have those same external factors influencing them to use, which is a long-term treatment plan. Okay, so from CRA, moving to 12-step programs, which I'm sure a lot of people have heard of. What a 12-step program is a set of guiding principles outlining a course of action for self-help recovery from addiction. Usually involves obtaining a sponsor. Original iterations of it were quite religious and faith-based, but then there have been many iterations since then where are less faith-based. In terms of 12-step programs for stimulant use disorder, limited studies, but according to the 2018 systematic review and meta-analysis, was found to be superior to treatment as usual for absence at the end of treatment specifically, but not really found to be more acceptable, or people didn't really like engaging with it compared to treatment as usual. And as everyone probably has surmised by now, less effective at achieving abstinence and lower acceptability in general than what they really recommend, which is contingency management and CRA combination. Okay, there was this large study, large-ish, for 471 people, comparing 12-step program integrating this intensive outpatient versus TAU, treatment as usual, for stimulant use disorder. I showed some mixed findings, some increased odds of abstinence during the active treatment phase. However, results were not statistically significant in the follow-up, as was with most of our non-pharmacological approaches. Okay, so if you look at something called the matrix model, which I think a lot of people have probably heard of, actually is basically a combination of a lot of different strategies, such as 12-step programs, CBT, family education, individual counseling, drug testing, motivational interviewing. Can be group sessions, can be individual sessions as well. Does the matrix model work specifically for contingency management, specifically for stimulant use disorder? It would seem that early evidence indicates that it seems that it could work for stimulant use disorder. There was this 2020 systematic review of non-pharmacological interventions for methamphetamine use disorder, included 4 studies comparing matrix model to treatment as usual or controls, showed some encouraging results. Some of those studies demonstrated superiority during the treatment, but as with a lot of other things, superiority not sustained at the end of treatment, and of course not at the follow-up after treatment was finished. Okay, so moving on to bed-based treatment or treatment centers, basically living as a type of facility, also known as a treatment center for some period of time, 30 to 90 days, can be longer as well. Very structured, very regimented. Folks there will have a schedule for everything, schedule for counseling, schedule for group sessions, schedule for exercise. It's a very structured way of living in treatment centers. Okay, so research for bed-based treatment for a lot of substance use disorders, and specifically stimulant use disorder, is very scarce. There was a systematic review looking at 2014, looking at bed-based treatments for various substance disorders, including stimulant use disorder, compared to other types of non-pharmacological treatment. Results were mixed, suggesting some improvement or no improvement. However, many methodological weaknesses in study designs. Based on the BCSU practice update 2022, it suggests that there can be some improved treatment outcomes for stimulant use disorder in terms of bed-based treatment. However, still limited evidence on it so far, but it may be beneficial for folks, especially who have tried treatment centers before and enjoy it or found effect from it, or have very tenuous living situations and could really use some stability in that particular standpoint. Okay, so application to practice. Just to summarize, as everyone probably understands now, contingency management alone or in combination with CRA or CBT was found to be effective in resulting in abstinence during active treatment and the end of treatment with adequate retention rates. And specifically, the combination of contingency management and CRA was found to be most effective at abstinence and most acceptable, and the only intervention that resulted in abstinence during treatment and in follow-up after treatment completion. Okay, so if anyone was particularly interested in establishing their own contingency management program in whichever setting they are in, I encourage you to look at these two articles referencing or relating to the Veteran Affairs Initiative that I mentioned a little while ago. The top second bullet under the first point, this paper basically speaks about the program at the beginning and how they implemented it. And then another paper was done basically analyzing the program, speaking to its results and some lessons learned as well. And there's a specific book or a guide called the Clinician's Guide for Implementing Contingency Management Programs by Nancy Petrie, which is basically a step-by-step guide of how one would implement contingency management, including the escalation of the prizes, how much prizes, the amount of the prizes, the contents of the prize bowl, and very specific details like that. So I encourage anyone who is interested in doing contingency management or creating a program to look at that guide. Okay, however, contingency management in general has had some important uptake for a lot of different reasons, such as costs, practical concerns, needing contingency management staff, spacing, as well as some philosophical objections regarding potentially rewarding folks for abstinence. So therefore, it can be inaccessible to many. Thus, because of that, it would be reasonable to trial other psychosocial interventions if contingency management is not available. I know a lot of the evidence is pretty sparse or pretty weak on that, but it's often worth a try if contingency management is not available. Matrix model so far showed some promising results. And to summarize the 12-step program, mixed evidence, definitely needs some more research, but may provide some benefit to those who had success with these programs in the past or have particular interest in it. Also reasonable to attempt trying a bed-based treatment if they have tried it before or have tenuous living situations for stimulant use disorders. Okay, so some resources in the Lower Mainland, contingency management programs that are out there. Pender CHC has a program, Downtown CHC has a program. They will often have wait lists and such like that. The St. Paul's Hospital Rapid Access Addiction Clinic, the RAC, has its own program, might be full, might have a wait list as well. And if you're in the Fraser region, the day, evening, weekend program out in the Fraser region, there's one in the West, one in Surrey, and one in Chilliwack. These are intensive outpatient programs. They often run a contingency management program as well. In terms of the matrix model, there's one in the Lower Mainland that I know of. It's the Vancouver Addictions Matrix Program, VAMP, at Three Bridges Community Health Center, which could be of interest to certain people. And in terms of cognitive behavioral therapy, interestingly about cognitive behavioral therapy, there's not really a dedicated CBT for substance use. A lot of the principles of cognitive behavioral therapy from depression or anxiety would be applied to substance use. With that being said, in terms of how someone could access CBT, if you're looking at online ways, there's certain apps that you could access, such as Mood Gym or Bounce Back. Bounce Back actually is something that consists of online modules and phone coaching as well. And then there's other apps such as Mind Over Mood, which is a physical workbook, which involves physical workbook, and Kelty's Key as well. If you're looking for in-person CBT, there are some places you can consider. The Vancouver CBT Center mostly does CBT for depression and anxiety, but some concepts of those can be applied to substance use. also through Smart Recovery BC and Smart Recovery through VCH. That involves linking with some smart counselor, and smart meetings are obviously different from CBT. However, a lot of the smart counselors are able to do CBT specifically for substance use, so that's something to consider as well. And in terms of the community reinforcement approach, not really a program someone can be referred to. It's more individualized to the specific patient, and any practitioner conceivably could apply those principles to someone. If you were looking to read about that a little more, I didn't include it in this particular slide, but the Canadian Center on Substance Use has a particular guideline on that, and that was published in 2017, I believe. However, upon my own research, the Salvation Army treatment program, as well as outpatient recovery program, operate under the principle of community reinforcement approach. So that's something that can be considered as well. Alrighty, so that basically wraps up my presentation. I have numerous references that I can interest you in. Otherwise, we can move on to questions if anyone has any burning questions.
Thanks, Kevin. That was a very well-run tour. I heard earlier a question coming from your room. Maybe we'll start there. Does somebody want to? Can you just repeat the question if it comes from anyone in the room with you?
Yeah, sure. I think Kira may have had a question. I'm not sure it's still relevant. Oh, already answered, Kira says.
You're too good. Okay, well, while others are formulating their thoughts, I'm curious if you know any other examples other than the VA in the US where contingency management has been rolled out in a more widespread fashion, or if you expect that to be happening, like what's happening in the research in this area for now?
Good question, Paxton. I'm not aware of anything right now. I'm not sure if you are. I am aware that I think there's some studies in RCTs, particularly in virtual contingency management right now, and those are cooking, those RCTs are happening. Other than that, I can't speak to it much more than that, disappointingly.
Yeah, I mean, it is a bit of a gaping void in the literature for something that has been shown so consistently to be effective in controlled trials. To see so little of it being evaluated in the real world is,
yeah,
I think it speaks to some of those barriers you've already highlighted.
Yeah.
What do your prizes look like here? Do you know?
Yeah, at the rack, I believe it's the draw based. If I'm correct. Yeah, yeah. So the question that asked was specifically what the rack's contents of contingency management program was.
Yeah, ours is lottery based. It's built very similar to the inpatient you have at St. Paul's. You can transition between the two programs. So there's up to two rewards per visit, one depending on your results and one depending on your whether you're achieving certain health goals.
What was it?
Achieving health goals. So they put things like attending your appointments or getting your investigation, like MRI, as a health goal, or getting a phone and things like that. Yeah, so specific health goals.
And is there a lot of uptake at St. Paul's into these programs, would you say?
Yeah, so there's a question, is there a lot of uptake into these programs at St. Paul's? I'm actually not unaware of that answer in terms of the programs you have in hospital. I'm sure someone else, possibly Paxton, be able to speak to that.
Yeah, I mean, I can't speak to the numbers that flow through that program. I can say that in our outpatient program, we consistently have a wait list to get into it. It's not prohibitive, but a couple of weeks. Our inpatient program, I don't know the numbers, but it was the subject of a study that was done. It was completed almost 2 years ago now, and the paper's still being prepared. But the inpatient program here, to my knowledge, is the first ever inpatient program that's ever been demonstrated, and so it was a part of a study that's funded by, I believe, the St. Paul's Foundation. The name of the study is now escaping me, but I expect we'll see those results sometime in the near future. And for what it's worth, our program was also used to adapt, or an adapted version of our program was used to set up an inpatient program in San Francisco at UCSF. They established a similar program based off of ours, so the concept is spreading. I see a note here from Raman that there's a verbal question from somebody in the audience. Do you want to unmute them, Raman, so they can ask?
Hi there, can you hear me?
Yes.
Hi, yeah, I'm from Island Health. I'm Ann Crawford, and we have a virtual group we've been doing for about 2 years. So we were trying to decrease some of the barriers of cost and administration and see if we can increase expansion of groups, because those I think are pretty big barriers to getting groups started. But we're in the very early days over here, so excited to hear about what others are doing.
Amazing. And I think you spoke at the BCSU conference.
I did, yeah.
Yeah. It was a great presentation. Yes, so great to hear what you're doing over there.
Thanks.
How do we refer to the inpatient emergency management program?
Good question. We have a logistical question. How is one referred to the inpatient contingency management program at St. Paul's? I don't know exactly, but I'm sure the social worker knows. Yeah, we're an addiction social worker, I would presume.
It's for inpatient only. So that if somebody's admitted and followed by our team, they have access to it. Okay, I'm not seeing any. Oh, here are some questions coming in now. All right, so Kevin, were participants included in studies if they had other concurrent substance use disorders, or were the majority of studies looking at people with specifically a stimulant use disorder?
It's a bit of a difficult question to answer. For most of them, they're looking specifically at folks with stimulant use disorder. But of course, there'd be a mix and some other studies looking at folks with different types of substance use disorders as well.
Okay, here's another question. So this one's a bit of a in parallel to what you're talking about today, Kevin. Somebody's asking, why are there not more advancements for prescribing stimulants for these clients? We offer so many medications options for AUD and OUD, not for stimulant use disorder. I wonder if many of these clients struggle with undiagnosed ADHD.
Good question. I'm gonna have to pull the above out of the scope of our talk today, being a non-pharmacological, being the non-pharmacological approaches to stimulant use disorder. And I wonder if someone could do a more detailed talk on pharmacotherapy in the future. So I think I'll probably just leave it at that, sticking with the scope of my talk today.
The short answer is the evidence is still being generated in that area. It's not particularly strong, but for anyone who's at the BCCSU conference this past weekend, there was one presentation by an Australian group on this exact subject, and we have a PRISM trial, a multi-site national trial in Canada, looking at Vyvanse plus contingency management for the treatment of stimulant use disorder. So trying to bring those two worlds together. So I don't see any other questions. So I appreciate it. I'll say we'll sign off. I'll say thanks so much, Kevin, for a really a whirlwind, but still very detailed review of the literature in this area. I think this is so relevant currently, as you've highlighted. The harms of stimulants are rising. We find ourselves really grasping for appropriate treatments, but the evidence is there for treatments like contingency management. It's a real challenge that these programs are so widely unavailable. So I hope people listen, are inspired to go forth and set up your own CM programs, if nothing else, by this. So with that, we will we'll adjourn, and we'll see everyone in next month's what's new.
Great. Thanks, everybody.